So welcome, I'm Michel Pollack from Paris, and I have the pleasure to be at the ESPE in Vienna and to interview Dr. Charles Sklar and Dr. Lars Savendal about the long-term endocrine consequences of cancer in childhood and also the use of growth hormone in that situation. So please, Dr. Charles Sklar from New York, the Memorial Sloan Kettering Hospital. Can you tell us about this late endocrine effect that you demonstrated in those children with cancer?
Yes, sure. I'm happy to go over the late endocrine effects in survivors of childhood cancer. As I showed in my talk earlier today, it really spans the full spectrum of endocrinopathies, hypothalamic pituitary disorders, with growth hormone deficiency being the most common, primary hypothyroidism, impaired fertility in males and females, premature menopause in females, the osteoporosis, and insulin resistance and the metabolic syndrome associated with type 2 diabetes are among the most prevalent endocrine complications that one sees in survivors. These complications are primarily the result of the treatments that the patients receive, with radiation exposure being the single most important risk factor for almost all the late effects that I discussed. High doses of alkylating agents, particularly in the context of an allo or auto bone marrow transplant, is also an exposure with a very high risk for reproductive adverse outcomes.
Can you tell us a little bit more about the growth hormone axis? When do the growth hormone deficiency intervene? Does time matters?
Sure. So in terms of the prevalence and onset of growth hormone deficiency, so growth hormone deficiency is seen really in two different settings. We see it in patients with tumors in or near the hypothalamus and pituitary, so either the tumor itself or the surgery for the tumors like craniopharyngioma. Growth hormone deficiency is highly prevalent, but overall among all cancer survivors, probably the major risk factor for growth hormone deficiency is exposure to hypothalamic pituitary radiation. So that's primarily seen in brain tumor survivors, but also to a lesser extent in individuals that have tumors of the eye, the nasopharynx, and the other regions of the face. Radiation-induced growth hormone deficiency is both dose and time dependent. So the higher the dose, so doses greater than 18 gray is kind of a threshold. So the higher the dose, the greater the risk and the earlier the onset. So patients who get 18 to 20 gray hypothalamic pituitary radiation are certainly at risk over a lifetime, but it can take a decade or two before growth hormone deficiency becomes apparent. Whereas patients who receive 30 or 40 gray, which is typical dose for many brain tumors like medulloblastoma, those patients have a very high risk of becoming growth hormone deficient actually within the first 5 to 10 years of treatment.
How would you go about the diagnosis? Which test will you use? And can you explain to us also why IGF-1 is not accurate in that situation to diagnose growth hormone deficiency?
Sure. So in terms of making a diagnosis of growth hormone deficiency following radiation to the hypothalamus and pituitary, it's just as it is in a non-cancer population, it's both a clinical and a hormonal diagnosis. So we test patients primarily who are demonstrating evidence of poor linear growth. In terms of the tests that we use, our recently published guidelines for the management of growth and hypothalamic pituitary disorders in survivors, after careful literature review, we came to the conclusion that there was no reason not to use the same secretagogues that we use in non-cancer patients to make a diagnosis in cancer survivors, with one exception, which is that growth hormone releasing factor, either by itself or with arginine, has been shown to have a very high false negative rate. So you get normal results in patients who are actually growth hormone deficient. But other than excluding growth hormone releasing factor as a secretagogue, any of the available stimulation tests seem to be appropriate. The reason that we suggest against using IGF-1 levels has to do with its very low sensitivity. And by that I mean that the vast majority of patients who are growth hormone deficient after radiation therapy will actually have IGF-1 levels that are within the normal range. It's only a very small percentage that have low levels. Very low levels in patients that get high doses of radiation are probably reasonably reliable, but that only includes a very tiny fraction of the population. So as a general rule, we don't feel that it's a useful or reliable screen. And so we go right to stimulation testing to establish a diagnosis.
My question will be directed now to Dr. Lars Savendal from the Karolinska Institutet in Stockholm. Basically, a lot of families and physicians are worried about the relationship between growth hormone and cancer. So maybe I should ask you 3 questions. The first one is there any relationship between growth hormone and the onset of a primary cancer in children? Then we will go to the primary tumor and recurrence. And the third question will be about the onset of a secondary tumor in a growth hormone deficient child who had a primary tumor. So please, can you answer in general growth hormone and primary tumors in children?
So there are 3 questions, thank you. Will growth hormone cause a tumor? Would it increase the risk for tumor recurrence or a secondary tumor? So first, will it cause? I mean, we have data from several observational studies, and we also have the SARCH study, clearly showing that there is no risk of cancer in otherwise healthy children with isolated growth hormone deficiency. With regards to patients with a cancer diagnosis and the risk of recurrence, there are convincing data that growth hormone does not increase tumor recurrence. When it comes to secondary tumors, there are different evidence in literature. There is a recent meta-analysis suggesting that there is no increase of secondary malignancy, but there are also other data, including data from the SARCH study, suggesting that there might be an increased risk of cancer mortality. Secondary tumor was not addressed in that paper, but there are other studies indicating that the risk of secondary tumor might be increased by growth hormone.
What about with long-term follow-up? How does that risk of secondary tumor evolve over time?
Thank you. It's a very important question, what happens over time. If there is an increased risk for secondary tumors, where there is suggestive evidence, this risk clearly diminishes over time. So I think you need to closely survey the patient, regular follow-up while on growth hormone treatment. And I don't know if Dr. Sklar agrees, but I think at least every 6 months to monitor the patient over the first 5 years or so. I don't know if you agree, Dr. Sklar.
Yes, absolutely. We follow all of our patients every 4 to 6 months.
Right.
But our follow-up is the same for cancer survivors on growth hormone as it is for children who are growth hormone deficient in a non-cancer setting. So we don't actually use a different surveillance or frequency, but I don't think there's any data to suggest that one needs to be, especially cautious or do things differently in that population.
I fully agree.
Regarding the use of growth hormone in these growth hormone deficient children with a cancer, would you use an IGF-1 based regimen to treat them, or would you not use it?
The short answer is no, I would not, as I'm not doing that in non-cancerous patients either. And with regards to dosing of growth hormone, I think that is a common question also. Should you use less growth hormone in a cancer patient than in any growth hormone deficient child? The recommendations is not to change the dose, so use the labeled dose of growth hormone. And to monitor IGF-1, I think most of us do, and have it more like a safety measure, and aiming to keep the IGF-1 within ±2 standard deviation. I don't know, do you agree, Dr. Sklar?
I do. We follow IGF-1 levels in our patients on growth hormone therapy. Were you asking whether we use IGF-1 or we use IGF-1 monitoring? I wasn't clear.
IGF-1 monitoring during follow-up.
Right, but not IGF-1 therapy. You weren't.
No, not
okay.
IGF-1 therapy.
IGF-based dosing we discussed on,
Right. But I will say that particularly in patients that, like the case that Lars presented, patients that get craniospinal radiation, which we know are relatively poor responders to growth hormone because the spine has been radiated, and the radiated skeleton is poorly responsive to growth hormone. In those patients, we try to use the highest allowable doses. We have shown in some studies that we've published in the childhood cancer survivor study that the change in height standard deviation in these previously spinal irradiated children is actually better at the highest doses of growth hormone compared with the lower doses. And I know we use different dosing in North America than in a lot of European countries, but there does seem to be some advantage of using a higher approved doses from the beginning in patients who've had previous craniospinal radiation. But in terms of monitoring, we do exactly the same as we would in a non-cancer growth hormone deficient setting.
My last question is in regards to the follow-up and the organization of care. So would you advise for an active transition from pediatrician to physician involved in adult medicine? How would you organize long-term follow-up for those children? Dr. Sklar.
Yeah. So how to follow these children in the transition is an extraordinarily complicated and difficult area. Remember that patients who are cancer survivors who have endocrine disorders almost certainly have additional non-endocrine problems, or they're at least at risk for cardiac, pulmonary, neurocognitive issues. And so do we transition them to multiple adult specialists? Do we hope that the endocrinologist will take care of all of their issues? Probably not. And so our own model at my hospital, which is particularly unique, and I think we're very privileged, is we actually have a multidisciplinary adult survivor clinic where people trained in internal medicine oversee all of the care and then refer them to multiple subspecialists. But as a pediatric endocrinologist caring for a cancer survivor, referring them to an adult endocrinologist is one piece, but it's only one piece of a very big puzzle. So referring from a pediatric endocrinologist to an adult endocrinologist will only solve very part of the problem. Somebody needs to be overseeing all the other issues that these survivors are at risk for, and that is a very daunting and difficult problem for most of us, and I think it's an unsolved issue. So, you know, it's a work in progress.
Okay, thank you, Dr. Lars Ravendal. Thank you, Dr. Charles Sklar. It was our pleasure to have this talk with this specialist of the care of children with late endocrine effect of cancer.